This recording will cover the GI content for this unit. So the gastrointestinal system, as you can see on that first slide, obviously has many roles. That's how we get all of our nutrients. So the system itself has to be set up to break those things down for absorption so it can be used by the body, but protect itself from the enzymes that are necessary in order to aid digestion. So again, series of tubes, got lots of systems that are tubes. This is sort of the standard, especially the intestines and the peritoneal cavity, but some of these layers hold true for the esophagus as well. But the GI structures basically have the same setup and are innervated by the autonomic nervous system. It's just that their blood supply is a little bit different depending on where you're at in the GI tract. So here I have it as the peritoneal area with the mesenteric blood supply, but that's obviously different for the stomach and esophagus, which get their blood supply from gastric arteries and other vessels. So there are layers in the GI tract. The top layer is considered serosa, which is the connective and supportive tissue of the bowel, and in the abdominal cavity that connects into the peritoneum or that sort of apron of the body, and that's where the mesenteric vessels are located. The next layer is the muscularis, and that is the layer that works with propulsion of fluid or food forward in the body, and that's innervated by the autonomic nervous system. The sympathetic nervous system would slow this movement down, and the parasympathetic nervous system would increase or speed up that motility. A little bit further in, the next layer, so it's serosa, muscularis, submucosa, is also innervated by the autonomic nervous system. There are glands in there that, under the autonomic nervous system influence, will either stop or decrease secretion or increase secretion in order to aid movement and digestion. And then underneath that is mucus layer, and in the submucosa, the glands there help produce the mucus. The mucus is protection of the tube itself. It contains immune materials like IgA, which is another type of antibody that is on the inner surfaces of the GI tract to help prevent infection. And that's where we'll find the villi, or the area of absorption, depending on where we're at within the GI tract. So we said already, the autonomic nervous system is the system that is in charge of innervating the submucosal and the muscle layer of the GI tract, but it's given assistance by specialized cells called the cells of Gallbladder. So the enteric nervous system is very complex. It's huge. It's kind of its own little separate nerve area of the body. These are cells that are in between smooth muscle cells, and they're always sort of cyclically bringing the membrane closer to action potential. And that activity can increase or decrease in rate, and make the sympathetic nervous system or parasympathetic nervous system will make it easier or harder to get to action potential. And it's sort of a way to be sure that the movement of the GI tract stays in that steady peristaltic waves. We don't want it to all contract at the same time. We want to be sure that it's this part contracts and then relaxes while this part contracts, so it's constantly sort of getting all the contents to milk its way through the GI system. So each section of the GI tract has its own job, as what you eat makes its way through your system. And of course, each section of the GI tract is subject to different disorders. So we'll sort of move down the GI tract, selecting certain disorders for each tract, which is obviously by no means comprehensive of all the disorders that can befall our GI tract. So any of those disorders could be motility, too fast or too slow, anatomic anomalies either that develop over time or you're born with. You might not absorb things correctly. You could be subject to inflammation and infection as well, and of course cancer. So we start out with the beginning of digestion of food, which is once we eat, our salivary glands will start to release enzymes that begin the process of digestion. And those glands, pictured on that slide 6, are responsible for releasing alpha amylase, which starts to break down carbohydrates in your mouth. The salivary glands are also under autonomic control, and if the sympathetic nervous system is activated, there will be decreased salivation because that's the fight or flight. So it's not time to get ready to eat a juicy steak if you're being chased by a saber-toothed tiger. But that would increase production of salivation if you started to eat, or with parasympathetic nervous stimulation, or a smell which brings to you the thought that you would maybe get to eat some food. Swallowing occurs. There are portions of your swallow that are voluntary mechanisms and portions that are involuntary. So during the oral and pharyngeal phase, the salivary glands release their secretions, which are already helping to break down the food. You mush up the food with your teeth, and you also kind of bring the food up to your palate and kind of make it into something that's easier for you to swallow. So during that's this voluntary phase of swallowing. So it's the superior constrictor muscle and epiglottis, and your breathing should be arrested at the time that the food is actually pushed back against the soft palate. And then the rest of that is brought on by the peristalsis of the esophagus to bring, once the epiglottis is covering the larynx, to bring the food down the esophagus and to make its way down that way. So you are mashing your teeth. So the picture is showing you the phases of swallowing, where the person is sort of bringing up the food against their palate. The epiglottis will close to allow finally the food to go down past the voice box into the esophagus, which will then complete that action by its peristalsis. So that following slide is showing you the position between the relationship between the esophagus and the trachea and bronchi as it runs through, and the aorta. They're all very close together there in the center. And you can see the layers of the esophagus there. There is serosa, there is mucosa and muscularis. There is, it is in charge of peristaltic waves that push the food down to the end of the esophagus, where that sphincter lies in the connection between the esophagus and the stomach. There is no absorption that takes place here. It's moving the food from the back of the throat, the pharynx, down to the stomach. So there are dysfunctions that can occur in the esophagus. There can be strictures in the esophagus. Anatomically, that could happen over time from different inflammation leading to scarring, or maybe that's just how your esophagus is shaped, which will make it harder for food to work its way down, or for you to feel like you can swallow it all the way down. You can certainly get ulcers in the esophagus. The two things that we'll focus for the esophagus are GERD, or gastroesophageal reflux disease, and hiatal hernias. So a hiatal hernia is a sliding movement between the esophagus, stomach, and diaphragm. So the diaphragm has a natural weakness in it. There's a hole in the middle of the diaphragm, and so the esophagus can go through the diaphragm. So we obviously needed that, otherwise the esophagus won't get down into the stomach. However, that could get enlarged, that area, and if that occurs, then it's possible that this opening here in the diaphragm gets a little bit bigger than usual. Here's our stomach. If that opening is bigger, then it's possible that the stomach, the top of the stomach, could slide up and down into the chest cavity. And so that person will feel occasionally like they're full because the stomach will be pinched by the esophagus, or sorry, by the diaphragm. So if the stomach comes up a little bit, like this, so here's part of our stomach is up, the person will feel like they're full because they can't get the food. This part is constricted, so it's harder to fill the stomach. But it'll slide back down and their symptoms might go away. So it's hard to catch because usually they are sliding. They have this slow movement from the esophagus to the stomach and can sometimes be confused with GERD. A paraesophageal hernia means that there's an opening here. Just like if there was a hernia on the abdominal wall that you get a bulge, and over time that bulge can get bigger, the same thing can happen with a paraesophageal hernia. So what happens is more and more of the stomach can come up and it's sort of stuck there. So it's much more uncomfortable. Over time, just like you could have a large abdominal wall hernia with what's called loss of domain, so just a huge hernia, you can get a huge paraesophageal hernia. And some people have them where part of their small intestine ends up in their chest too. So not only do they have GI symptoms, but they might have shortness of breath and other respiratory system symptoms because they've decreased, they're pushing on the lungs if the GI contents start to get into the chest cavity itself. So with gastric esophageal reflux disease, it's not that there's a hernia or a widened opening in the diaphragm. The diaphragm is not the problem. The problem instead is the lower esophageal sphincter. So under vagus nerve stimulation, which is the parasympathetic nervous system, and as food peristalsis down the esophagus, this lower esophageal sphincter should open so that food can get down into the stomach, and then eventually, as the food falls through gravity into the stomach, this sphincter should close. So if the lower esophageal sphincter doesn't open all the way or is somehow stenotic, then food feels like it's stuck here, and the person feels like they have pain right here because the food can't get down through into the stomach. What else can happen is that this lower esophageal sphincter could be weak. So now, after the food contents get into the stomach, this esophageal sphincter should be closed because one of the jobs of the stomach, there's another sphincter down here called the pyloric sphincter. The job of the stomach is to propulse this food back and forth. It's called gastric churning. So the muscles of the smooth muscle of the stomach has its own pacemaker and will cause a contraction that pushes the food towards the fundus of the stomach or the top of the stomach, and then the food drops by gravity back down to the bottom of the stomach, and then the stomach contracts and propulses the food, so it keeps getting churned up in the stomach's acid in order to break down even further. So if this sphincter is weak, then when the stomach is doing its churning, some of the acid and food contents may come up into the bottom part of the esophagus. Or during times of gravity, such as persons laying down, this could open and allow food to come into this lower segment of the esophagus. And what that does is the stomach is very, very acidic, but the esophagus isn't built for that acid content. So this will cause irritation and inflammation. And that is painful. So the patient will experience what they commonly describe as heartburn. But the other worry is that chronically, this could change the actual cell type of the esophagus, like we talked about in the first class. This squamous epithelial cell will develop metaplastic changes and could potentially become dysplastic, which is what Barrett's esophagitis is. And this continued inflammation is thought to be implicated in why people might develop gastric esophageal junction cancers. So we certainly wouldn't want that to continue. So as we started to talk about, the stomach's job is to churn the food around and mix it with its hydrochloric acid to assist in food breakdown and the development of chyme. And the other thing is there is some absorption that occurs in the stomach and some enzyme activity. One enzyme that's created in the stomach, which is activated in the stomach, is pepsinogen, becomes pepsin, and we start to break down proteins in the stomach. And hopefully, I'm going to cover it up with my body here. You should pause and remember what other vitamin is absorbed in the stomach and is implicated in pernicious anemia. So you're pausing so you can answer this question. And then you said, of course, that the gastric parietal cells need intrinsic factor in order to absorb B12. And if not, then the person will have B12 related anemia, because you remembered, right? So in the presence of food, gastrin, which is a hormone that the stomach makes, is released, and this further releases histamine, and the parasympathetic nervous system under the influence of the vagus nerve will increase the production of hydrochloric acid. So we already know that the food fell through gravity from the fundus to the stomach and slides down in the antrum of the stomach, or the bottom of the stomach. And there's a gastric pacemaker that causes propulsion of food towards the lower esophageal sphincter, which then again falls for the gravity and then comes back where there's contraction. So we're churning and mixing the food. Gastric parietal cells, we said those were responsible for with intrinsic factor absorption of B12 into the bloodstream. We know that the other cells of the stomach, there's cells that secrete mucus, and we know that that's important to protect the stomach from itself, essentially. We know there is the endocrine function of the stomach, which is production of gastrin. The way that the body, in the response to gastrin, histamine, and vagus stimulation, increases the production of hydrochloric acid is by allowing chloride to continue to come through the bloodstream into the stomach and running this proton pump to allow hydrochloric acid into the stomach. This proton pump exchanges hydrogen for potassium so that together you'll get the hydrochloric acid that's needed for the stomach. Sorry, I had to take a break to yell at my dog. So, gastrin, as we said, aids in the secretion of gastric acid and pepsinogen, increases blood flow, and stimulates contraction of the muscle of the stomach. Gastric acid or hydrochloric acid and pepsin production is ongoing in the stomach. So there are a billion of these parietal cells in the stomach that secrete hydrochloric acid, and the chief cells secrete pepsinogen, which becomes pepsin in the stomach. And so we need to protect the parietal cells and chief cells from the things that they make, because that will break those tissues down. They're constantly making these factors, even if, and that ends up going into the small intestine eventually. So people are always making gastric juices, even without the presence of food, and that's why when people say, "Oh, I haven't eaten anything, how can I throw anything up?" You could still throw up those juices. So we have to protect the stomach from itself, essentially, which is to make the gastric mucosa, which is highly resistant to the acid secretions and the pepsin, because the acid would break down the parietal and chief cells, and the pepsin breaks down protein, which is also what the parietal and chief cells are made out of. So people can develop ulcers or inflammation and erosion of the stomach cells if there's trouble with the mucosal lining. And it's common to have trouble with the mucosal lining for several reasons. One, NSAIDs, because we know that NSAIDs are COX-1 and COX-2 blockers, and those prostaglandins that are cytoprotective help increase gastric mucosa production. If those are blocked, then we can't have that. Smoking, alcohol, and other chronic diseases are increased stress to the stomach and can promote ulcer development. But one of the leading causes of ulcer development in the stomach is H. pylori bacteria. So H. pylori bacteria are shaped like this. They have a flagella at the very bottom of them, and what that flagella is really good at doing is breaking down the mucosal layer. There's enzymes in there that break it down and then weaken that mucosal layer so that the stomach can get inflamed and ulcerated. The consequences of an ulcer are either that here I have this injury from an ulcer, and then I try to heal it, and I might have obstruction someplace. If I have this healing area, it might be hard for food to come down this way or food to get out this way. I could, come down, erode this so far down that the stomach could actually perforate and cause a peritonitis. And always, that's what we talked about with GE cancers, any chronic irritation, inflammation can lead to the development of malignancy because it promotes cellular change. Then as we work our way down, so we age the stomach, the sphincter opens, food enters into the first part of the small intestine, the duodenum, which is another very, very busy part in terms of digestion. So here's the stomach going down into the first part of the small intestine. This is our liver, the right and left hepatic ducts, and the common bile duct coming down into the first part of the small intestine. And here's our pancreas running behind the stomach. The pancreatic duct also empties right next to the bile duct into the first part of the small intestine, making this connection. If this is the first part of the small intestine, bile is coming down here, and pancreatic enzymes are coming down here into that part. And this is the sphincter odi. Sometimes this area is called the ampulla. And then of course the other thing that's over here, connected off the side against the cystic duct, is the gallbladder, which is a storage depot for bile, sometimes described as the purse of the liver. So, okay, the food is in here. We released gastrin in order to assist in mixing, churning, and taking care of the food that's in the stomach. The stomach also releases other hormones. One of them is called cholecystokinin, which is sometimes referred to as CCK, which will cause contraction of the gallbladder so that we have an increase in bile in the first part of the small intestine, and help stimulate secretion of the pancreatic enzymes into the first part of the small intestine, sort of getting this area ready for when the food comes. The other thing that is released is called secretin, which stimulates secretion of bicarb solution from the pancreas and the liver in order to protect this first part of the small intestine from the stomach contents, because it's going to be very acidic. So we get bicarb to go in there to sort of neutralize the acid. We get the gallbladder and the liver to bring bile into the first part of the small intestine, which will assist in emulsification and breakdown of lipids and fats. And we get the pancreas to release its enzymes to help break down the rest of our food components, because it releases amylase, lipase, and proteases to break down sugar, fat, and protein. So all that is done in anticipation of the food bolus that's going to be coming into the first part of the small intestine. So here we are looking at the gallbladder, which stores the bile, and the pancreas, whose exocrine functions are to release those enzymes. And they're both supposed to empty here into the small intestine, as well as bicarb to assist with, to assist with digestion. So the stomach releases cholecystokinin, which causes contraction of the gallbladder to allow a bolus of bile down into the first part of the small intestine. And so we want there to just be bile in here. The problem is sometimes people will develop cholelithiasis, which is a stone in the gallbladder. Some people, there's a genetic disposition towards this. There can be other issues with the gallbladder function itself, where it doesn't contract like it's supposed to. There could be issues with how the person processes bile, and so their bile is a little bit different. A lot of times, the reason it's associated sometimes with obesity and diet is that supersaturation of bile with cholesterol helps promote the development of cholelithiasis. So there is some relation to weight and dietary choices. So if I start to get stones in here, that's called cholelithiasis. And just having that stone doesn't necessarily mean anything. A lot of times you could have fall into some kind of scan or have an ultrasound and there will be a couple stones in there. As long as the stones aren't doing anything and you're not having any trouble, it doesn't necessarily mean that you need to have your gallbladder out. That, of course, changes if you develop what's called symptomatic cholelithiasis. What that means is that the patient is having issues with stones traveling through or stones blocking up this duct. So they could have multiple stones or they could have one really, really big stone. So then when they eat a fatty meal and the gallbladder contracts, the stone comes here and doesn't allow bile to go through. And so that is very painful. Or this big stone comes up to the common bile duct and doesn't allow bile to go through. That becomes very painful. And it doesn't stop the liver from necessarily increasing the amount of bile in the gallbladder, which will pretty soon distend the gallbladder, potentially causing tissue damage and necrosis. So that's one way you can get symptomatic cholelithiasis, which could eventually lead to an acute cholecystitis, which is inflammation of the gallbladder. Or what can happen is one of these tiny stones could flip out during gallbladder contraction, and the patient will have colicky pain as the stone goes through that small tube, much like if a person passes a kidney stone. So you could have symptomatic colicky cholelithiasis because your stone traveled through the common bile duct after you ate a fatty meal. Or you could have the gallbladder isn't releasing the bile correctly because of stones blocking transit of bile. But then the liver keeps producing bile, so the bile is stuck in there and starts to stretch the gallbladder and cause tissue damage and inflammation, which is cholecystitis. Sometimes people have what's called choledocholithiasis, meaning the stone moved and is stuck. If the stone is stuck, then it's choledocholithiasis. And depending on where it's stuck, can cause different symptoms. So if the stone gets stuck in the cystic duct, then I can't get bile into the gallbladder or bile out of the gallbladder, and it becomes inflamed, causing cholecystitis. If I have a stone stuck in the common bile duct, then I have issues with bile coming out of the gallbladder, and I also have issues with bile coming down from the liver. So I could develop cholecystitis as well as hepatitis, just as inflammation of the liver. Or if that stone gets stuck where the pancreatic duct and the common bile duct come together, then I could develop hepatitis, cholecystitis, and pancreatitis. Everything's inflamed because I'm not allowing anything to get down into the gallbladder. Gallstone pancreatitis is one of the top reasons why people need their gallbladder removed, and what is part of the top 3 reasons for pancreatitis to begin with. Pancreatitis can be caused by gallstone pancreatitis, which is an indication for gallstone removal, because if it happens again, it has a 20 to 30% chance of happening again if it happened once. And pancreatitis is a very dangerous condition. Alcoholism causes pancreatitis, or abnormal anatomic problems with the pancreas, or excess triglycerides. So, pancreatitis is inflammation of the pancreas because of obstruction or poor flow of those enzymes. And the problem is, so the enzymes are still being made, they're trying to get out, they can't. What happens is they start to auto-digest the pancreas itself. And if that occurs, of course, that would be very painful. The pancreas is making enzymes that break down sugar, fats, and carbohydrates. And so that's what the pancreas is made out of. So it can actually quite commonly lead to cellular injury, necrosis, hemorrhage. You can have translocation of bacteria from the bowel into the body that can become septic. You can develop fluid collections, which can also be infected. This has high morbidity, so we definitely would want to avoid that. So, and then moving to the liver. So obviously the liver has many, many jobs. It's part of the breakdown of lipids in order to make cholesterol. It's a part of carbohydrate metabolism, which we'll talk about when we talk about diabetes next lecture. It's part of production and metabolism of proteins. And it produces bile, which is done through the breakdown of red blood cells. And it's in charge of detoxification of agents like alcohol or drugs or other things that we ingest in excess. And it also helps in the metabolism and function of steroid hormones. So it has many, many jobs. So if something's wrong with it, the person is going to feel that in many ways. The liver itself is, which is the next picture, so we're on slide 31. Hepatocytes, that was just my cat. There is a picture of liver cells with a vein in the middle, and then the bile canal, a portal vein, and the hepatic arteries are all sort of intrinsically connected, bile, portal vein, arteries. And you can see that there's a lot of veins in the liver. And that is because, besides, of course, there's always artery and vein pairing everywhere, there's a special venous circulation called a portal circulation. One of the areas where portal circulation occurs, where there's just communication between 2 separate places through a network of venules. And that is between the small intestine and the liver, which is how the liver can detoxify some of the things that we eat or ingest or drugs. That's part of the first pass effect of medications that you learn about in pharmacology again. It's how the liver detoxifies alcohol before it can really affect us as much as it possibly could. Because this is the first part of the small intestine. When you eat something, this shared circulation, this absorbs into the portal circulation, which goes through the liver, and the liver empties into hopefully you are shouting it out, inferior vena cava, which goes to the heart, pumps into the lungs, and then finally out into the systemic circulation. So this is sort of our first pass of whatever dumb thing we decided to eat or drink, or any medication we took, etc. So having a good functioning liver is very important. So that next picture is a reminder of the breakdown of red blood cells. So red blood cells are broken down into heme and globulin, the proteins. The heme is broken down into one of the precursors of bilirubin, as well as iron. So we talked about iron circulation and how that is reused. Also partly stored in the liver and then partially stored and traveling to the bone marrow in order that we can keep producing red blood cells that are able to complex oxygen. The precursor bilirubin is changed to bilirubin in the plasma and then goes through the liver to either be conjugated or to be conjugated. So the bilirubin that is conjugated goes through through the bile duct, like we just talked about, where bile goes, but this bilirubin goes through there into the first part of the small intestine and can go through the portal circulation back into the liver to be recycled, because we still need bilirubin and bile for the precursor for bile for other things, or it can go down through and out the feces, or it can go into the general circulation, and because it's conjugated, go out into the urine. So the liver is very, very important in getting rid of bilirubin, in conjugating the free bilirubin, and it'll be part of the bile precursor going into the small intestine, some of it going out through the stool, some of it being recirculated into the liver through the portal circulation, and some of it getting into the bloodstream and going out through the kidneys. So the way, because the liver is so involved in the process of breakdown of heme into bilirubin, if there's problems with the liver's functioning, the way the liver is handling bilirubin is a clue. If there's a backup in this processing of bilirubin, because and so that there's this excess, instead of being made into bile and secreted into bile, that we're starting to get more in the stool, more in the urine, and more in the bloodstream means more in the cells. So jaundice, which is the intracellular accumulation. We can use the fact that this liver is always busy with bilirubin to help us know about its health. So we know that if someone has an excess of bilirubin for some reason, they're going to have jaundice. And if there's excess bilirubin going through the stools, they're going to have white stools. And if there's excess bilirubin going through the urine, they're going to have darker urine. So if that's happening, then we have to figure out the reason. Is it prehepatic, intrahepatic, or posthepatic? So we just talked about posthepatic reason for hepatitis or liver issues, which was obstruction of bile flow. So if I have choledocholithiasis, I have a stone in the common bile duct, then I have a backup of bile and bilirubin in the liver, which would cause jaundice and hepatitis. And hepatitis is a general term. Sometimes people get confused. Oh, hepatitis, are you talking about them having a virus? Hepatitis just means inflammation of the liver. So posthepatic reason would be obstruction of bile flow. So we just said one, choledocholithiasis. A prehepatic reason, meaning the problem is above the liver, it's not the liver itself, will be what we talked about in the first units as hemolytic anemias. So if for some reason my spleen was destroying red blood cells early, I'm going to have an excess bilirubin that the liver has to deal with, and so then I'm going to get jaundice. So that was sickle cell anemia, the thalassemias, something like that. The intrahepatic reasons will be the liver itself is injured, and so it cannot process the bilirubin correctly. And so it's overworked. Whatever cells are functioning can't do what they're supposed to do. That's an intrahepatic reason, and it's liver damage that caused the problem. And so, yes, viral hepatitis would be a reason why that would occur. Cancer is a reason that could occur. But it could also be liver injury related to alcohol use or fat accumulation, which in our country with the obesity epidemic is a reason for people to develop hepatitis. Fat accumulations in hepatic cells. Fat accumulation is an injury related to cellular accumulation. So the hepatocytes, one of the things we eat are lipids, which we talked about cholesterol, triglycerides, which we talked about last class when we were talking about lipid metabolism, which goes through the port of circulation into the liver, into hepatocytes, because it's supposed to be packaged by the hepatocytes into chylomicrons or LDLs, etc. So if we have more than we need, then we're going to have excess accumulation of fat in the cells. And the liver will try to break the excess fat down. It'll try to catabolize it to get rid of it. And that causes the production of active metabolites inside the liver in our attempt to break the fat down. Metabolites. That's not spelled right. In our attempt to break the fat down and get rid of the fat inside the blood cells, we will actually expel into the extracellular matrix some of these active metabolites, which will draw macrophages to the area to get rid of it. And that means we're going to have an increased amount of macrophage activity and increased amount of swelling. More fat. So let's talk through that again. So we're eating a lot of lipids, we're eating a lot of triglycerides, we're eating a lot of fats. Those are supposed to be taken up through the port of circulation into the liver hepatocytes. The hepatocytes, one of their many, many jobs is to help process that into chylomicrons and our LDLs and HDLs. If we're not allowed to do that, then the liver has accumulated fat inside of it. It will try to break it down or catabolize it. So excess fat in the liver actually does change the liver. It becomes larger because there's increased fat in it, and the color changes if you would see it when you with surgery. So there is a capsule of connective tissue around the liver. So if the liver is becoming enlarged because of increase in fat inside of it, people can have some low-level pain occasionally in their right upper quadrant because that capsule is stretching. They might not feel it at all or could have some discomfort. It might sometimes account for a little bit of increase in their liver enzymes, but it's definitely not as destructive as if this inflammation occurs. So the first thing I talked about was non-alcoholic fatty liver disease, meaning I have increased fat accumulation in my liver cells, therefore have caused some hepatomegaly and some stretching of the capsule. If I don't change that, or for a certain percentage of people, that'll change into non-alcoholic hepatitis or NASH, steatosis hepatitis, because the liver's hepatocytes are going to attempt to break down that extra fatty cells, the actual fat that's inside, and they're going to get rid of some of those metabolites that are created by their breakdown of the fat. And our immune cells will try to get rid of those metabolites. So we're drawing immune cells into the area. We will cause inflammation and increased swelling. This should potentially cause increased pain for the patient, but it will also show increased liver damage. So there will be start to be an increase in bilirubin in the bloodstream and jaundice potentially, or there will be increase in liver enzymes because there's going to start to be more cellular destruction of the liver. Eventually, this could lead to cirrhosis. The same sort of process of active catabolism of intracellular accumulations occurs with excess alcohol. It's just that it's alcohol that's going through this instead of fat. So the process is very similar. There are videos about alcoholic and non-alcoholic fatty liver disease, which I highly recommend watching. However, if you just go in there and try to watch them, it won't work. You have to subscribe to the Osmosis channel, which I highly endorse. I think it's a very nice way to describe some processes with pictures, and they do a really good job describing this process in a little more metabolic detail. So you don't have to pay, you just have to like and subscribe so that you can see more of that material. And I really recommend doing that. But anything that increases inflammation could eventually lead to cirrhosis, which is scar down or fibrosis of the liver itself. That increased inflammation, again, is a precursor to potential cancer development. And it's also a cirrhotic liver. Is that rock? So remember the first class we talked about reasons, that could be a reason to develop ascites. So I'm trying to get fluid to go through a very hard liver. I'm going to have an increase in hydrostatic pressure, which could lead to fluid in the abdomen. So the liver, we just said, was in charge of all kinds of things. So the person is going to have evidence of excess bilirubin. The person is going to have issues with the breakdown of certain steroid hormones. So sometimes they do seem to have excess estrogen because that's a steroid hormone. You might see decreased protein production, certainly decreased albumin, which also leads to edema. The liver is in charge of making clotting factors, and so you might have excess bleeding. The liver is in charge of metabolism of drugs, and so doses have to be adjusted. So everything that the liver does is going to be touched by its inability to work. So people can be very, very sick from liver disease. So the small intestine is a very active place. So there's three parts of the small intestine: the duodenum, jejunum, and ileum. The duodenum is very, very busy in terms of absorption of vitamins, minerals, fats, carbohydrates, proteins, etc. And that's true of the small intestine in general. There's not water absorption, but lots of nutrient absorption. And the first part and last part of the small intestine especially, that ileum is another area where vitamin B can be absorbed too. So the disease that we're going to talk about affecting the small intestine is a disease of malabsorption, which is celiac disease. So the small intestine, if you see on the picture that's located on slide 37, again, it has all those layers that we talked about: the serosa, muscularis, submucosa, and mucus layer. And the small intestine itself has a huge surface area for absorption because of its many, many villi. And that is what we need, that villi, in order to get absorption. If we develop an infection in the small intestine, an enteritis, inflammation, then that inflammation flattens. So here's my villi for my small intestine. If this is inflamed, then the villi get flattened and there's less ability to absorb food. So there's going to be more that gets to the colon, and that's one of the reasons people can develop diarrhea. So why would people get inflammation of the small intestine and lose surface area from the villi? Well, one of those reasons we said could be infection. The other is celiac disease, which is an autoimmune reaction or inflammatory reaction to gluten. So the true celiac person, this is a genetic disorder in which when gluten is introduced into the small intestine, creates a hypersensitivity response, increased inflammation, which changes the depth of the villi and leads to decreased absorption and to diarrhea for that reason. So the large intestine, there's no nutrient absorption in the large intestine. The large intestine is all about water absorption. The way the large intestine works is, again, we have serosa, we have muscle, and we have some submucosa, but the difference in the large intestine is there are circular muscle bands that create that intestinal haustra, large intestine haustra that you would see where it looks like that on an image. So what happens is when the small intestine gets through the ileocecal valve into the first part of the colon, the right side of the colon, the way the large intestine moves is those bands in here will move, pushing the waste forward and sort of squeezing it out like a sponge to get the water out. So we have these continuous muscle bands that'll propulse the waste forward and squeeze out the water. So a common thing that can occur in the large intestine is, especially in Western cultures or people with a low fiber diet, is the development of diverticulosis or diverticula. So if the person doesn't have a very bulky stool, their fiber content is low, then it takes a lot of pushing, a lot of squeezing of these circular bands of muscle to get the waste to go forward. And sometimes that squeezing will cause an outpouching or a little pocket to develop on the large intestine. And that in and of itself is called a diverticula. And it's very common to occur, especially at the very bottom part of the colon, the sigmoid colon and left-sided descending colon, as we're getting, the waste has less water in it, and we're trying to push it forward. This is a naturally weakened part because this is where the blood vessel goes in to feed the colon walls. What can happen over time is stool can get into these little pouches. So that stool can lead to inflammation, which is the experience of diverticulitis. Diverticulitis, once it happens, could happen again. The worry with this is that inflammation could get so great that we could cause a perforation and an abscess to form. The best way to prevent that is to increase fiber in our stool so that it's not as hard for our large intestine to push our waste forward. Sometimes people will say, oh, avoid things with seeds, because I can get caught in these pouches. There are anecdotal evidence of that. People will say, when I have popcorn, that's when I feel really sick. But the evidence shows that you could avoid that and still get diverticulitis if you develop diverticulosis. And lastly, the bottom part of the colon into the rectum. And this is the rectum as we get to the dentate line. That's the end of the rectum and into the anal area, which is separate. Sometimes people will talk about anus and the rectum interchangeably, which is really incorrect. The colon itself is the ascending colon, the right side of the colon, transverse colon, descending colon, sigmoid colon into the rectum. The end of the rectum is here at this dentate line, and then the rest is the anal area. It's a separate type of tissue with separate functioning. So, and obviously different things that can go wrong with it. So there's veins here, or hemorrhoidal veins, and the muscles. So one of the biggest jobs of the anal area is continence. So as you're pushing the waste forward, the stool ends up at the bottom of the rectum here. Obviously, we don't want it to just fall out. That would be a problem. As the rectum gets stretched, that is a stimulus to the internal sphincter muscles. That stretch sends a message to the parasympathetic nervous system. Those internal sphincter muscles will relax and send a message to the brain that it's time to go find a place to go to the bathroom. We want the external sphincter muscles to be working. That's under our voluntary control, because if we're not at a place where we can go to the bathroom, we certainly don't want that to occur. After a while, if we don't go, that feeling will go away. The message to the brain will dampen. But that internal sphincter is still open, and it's our control of the external sphincter that has the stool wait to exit. Because this muscle is actually kind of closed off, contracted that external sphincter. And it's when we bear down that we're actually opening the external sphincter to allow the stool to pass. So one of the things that are very common to occur in this area, of course, is incontinence. If there's any damage to the external sphincter from labor and delivery, if there's any damage to the pudendal nerve, which is the source of innervation of our voluntary control, then we can develop problems with continence. But certainly this anal area can develop its own issues. Constant straining can cause backflow of the veins that are here. So just like you can get varicose veins or swollen veins in your legs because of backflow of fluid because of prolonged standing, you can get backflow of venous blood near the anal area from excessive straining. And hemorrhoids in and of themselves aren't dangerous, they can just be annoying. You can get skin tags or papilla, which are excessive skin growth at the dentate line. It's an area that can get infected because there's little what are called crypts that release mucus to help pass stool, and you can develop fistulas in this area as well. But the main thing that we talked about there is continence. And that's the end of that lecture. It's kind of a longer one. If you have any questions, please let me know.